Today we'll discuss ERAS in cardiac surgery. ERAS stands for Early Recovery After Surgery. Today we'll try to discuss what is ERAS and what are the things we have to do or we should do perioperatively to achieve ERAS. ERAS is a multidisciplinary approach which is aimed at providing best practice interventions and therapies throughout the perioperative encounter. It is the adoption of evidence-based protocols that have been published and serially updated. High compliance with these protocols is shown to reduce surgical insult, promotes recovery, and prevent post-operative complications. Today, we'll try to discuss ERAS with the help of all the evidence-based practice and guidelines. The factors which are important perioperatively for ERAS have been categorized as a preoperative, intraoperative, and postoperative factors. Preoperatively, we'll see one by one what are the important factors. First is shared decision making. Second is formation of a team. Third is good pre-anesthesia and pre-surgical evaluation. The fourth is prehabilitation, which is called as pre-operative rehabilitation, and limiting NBM status. Shared decision making, patient engagement, and education is very important as a basic principle of ERAS. Establishment of a multidisciplinary team. Apart from the surgeons, the core representatives such as anesthetists, intensivists, perfusionists, cardiac rehabilitation specialists, nurses, allied health worker, pharmacists, dietitian should all be included as a team for perioperative work. Program implementation and sustainment is facilitated through the establishment of a multidisciplinary team, including a dedicated coordinator as an extension of the heart team. Apart from team, a regular compliance and audit outcomes should be done as a routine part of our training and work. Apart from a good pre-operative anesthesia evaluation, there are some points which are important from ERAS point of view, which sometimes we neglect or tend to neglect, but they are very important for post-operative outcomes. First of all, we should always stratify the risk from STS predicted risk scores and Euroscores too. We should always do a frailty assessment preoperatively. What is frailty? Frailty is cumulative decreased physiological functions of overall body, which makes an individual vulnerable to the stress events like surgery. Pre-frail and frail status is associated with marked increase in morbidity and mortality. We should always look for what are the risk factors of delirium. Increased age, frailty, pre-existing cognitive issues, and mood disorders and excessive alcohol use are the risk factor for delirium. Increased HbA1c more than 6 to 7% is an indicator of poorly controlled diabetes and predictor of postoperative complication like deep sternal wound infection. Serum albumin level less than 4 is a predictor of increased postoperative mortality and morbidity. Urine albumin level increase indicates postoperative kidney dysfunctions. Obstructive sleep apnea is associated with postoperative respiratory complications. And we should always assess opioid tolerance because chronic pain and substance use contributes to hyperalgesia and opioid tolerance. A preoperative assessment can identify patients with opioid tolerance, establish appropriate expectation, and individualize their pain management plan. This is the new term prehabilitation. It is preoperative rehabilitation. What is prehabilitation? We'll see. Cardiac surgical patients are typically frail and they experience higher rate of postoperative morbidity, mortality, and prolonged hospital length of stay and associated increased cost. This is further compounded by malnutrition, which is evident in 20% of the patient. A comprehensive rehabilitation include patient education, nutritional optimization, exercise training, social support, and anxiety reduction. Limiting the NBM status as per the guidelines is very important. In India, it is sometimes extended too much. Limiting the NBM status to 6 to 8 hours to solid food and 2 hours for liquid food should be done and not extending beyond this. Now we'll see what are the factors intraoperatively so that we'll have early recovery after surgery. First thing, use of transesophageal echocardiography. All the recent guidelines and evidences says TE is encouraged in a patient with moderate to high risk perioperatively and it decreases morbidity and mortality. There are many evidence for lung ventilation perioperatively and they have been categorized as protective lung ventilation. What are the factors included in protective lung ventilation? It is a low tidal volume ventilation, which is around 6 to 8 ml per kg, in conjunction with PEEP and alveolar recruitment maneuver. Protective lung ventilation reduces postoperative pulmonary complications and helps in early extubation and early recovery. There are many studies which compared should we ventilate on CPB or not, and several randomized studies investigated different ventilation strategies, but they did not find any difference in postoperative complication between the ventilation and non-ventilation strategies. So the role is uncertain. Should we put PA or not? There is a lot of controversy, and this is a very evolving topic also. What data says? Data says use of PA catheter in low risk and clinically stable patients leads to increased intervention, but it is not associated with any improvement in morbidity or mortality. And in high risk patients, they have done a trial which include almost 2 million patients. What they say in high risk patients? In high risk patients, it is associated with longer periods of mechanical ventilation and prolonged length of stay in ICU. Basically, evidences are not very in favor of PA catheters. There is a lot of buzz around central nervous system monitoring under GA in cardiac as well as non-cardiac surgery. But evidences say it is unclear which interventions are optimal for prevention of neurologic morbidity in patients undergoing CABG. Although there is an association between a persistently low intraoperative processed EEG on bispectral index and postoperative mortality. The use of monitoring method for prevention of recall, assessment of depth of anesthesia, and its association with improved recovery has yielded inconsistent result. So, central nervous system monitoring may provide an early indication of neurological risk, but additional studies are necessary to identify strategies to prevent and mitigate the injuries. We should always look for prophylaxis and prevention and treatment for postoperative nausea vomiting because it is one of the greatest contributory to the patient dissatisfaction after surgery. It is as similar as a poorly controlled pain. Prevention and prophylaxis should always be included in our perioperative area. When should we extubate? Early, on table, within 1 hour. There are a lot of evidences which have different guidelines and protocol, but as a consensus, early extubation, which is called as fast track extubation, within 6 hours of surgery, it should be practiced for low risk and certain high risk procedures, and it is associated with reduced ICU length of stay and hospital length of stay. There are some published guidelines for intraoperative extubation. I think the intraoperative extubation, they mean to say on table or within 1 hour. They say both are safe, feasible, and they have found a similar reintubation and overall complication rate with standard extubation protocol. So the study says even you extubate within 1 hour of surgery, the reintubation and the complication rates are same as fast track extubation, which is also around 6 hours. So a structured strategies to facilitate extubation within 6 hours of surgery have been shown to be safe and potentially hasten the recovery. And a very highly selective intraoperative or immediate postoperative extubation may be appropriate for undergoing low risk surgeries. Acute kidney injury. The incidence of acute kidney injury postoperatively is very high. Approximately 20 to 40% of the patients experience AKI after cardiac surgery, with increasing risk of developing CKD postoperatively. And it increases short-term and long-term mortality. Among the patients with the evidence of postoperative AKI, early implementation of KDIGO, this is Kidney Disease Improving Global Outcome Guidelines. These have been recently published and they have given a guidelines for intraoperative and postoperative kidney care. What they say, what we should do a serial monitoring of serum creat, strict urine output quantification, volume replacement based on advanced algorithm, maintenance of hemodynamic targets, and avoidance of nephrotoxic agents. If we do this, we can reduce the rate of stage 2 and stage 3 AKI after cardiac surgery. We should always encourage post-operative activity for early ERAS. Early ambulation is safe and associated with decreased atelectasis, decreased pleural effusion, pneumonia, and a greater exercise capacity. And it all leads to decreased ICU length of stay and decreased hospital stay. So early postoperative ambulation and upper extremity exercise is well tolerated and associated with fast recovery. Perioperative pain management, it is the most important pillar of ERAS, especially from anesthesiologist point of view. So what are the guidelines say? Opioid sparing multimodal approach along with regional anesthesia or analgesia techniques should be included in our day-to-day practice to reduce pain management and achieve ERAS. Perioperative blood management program is one of the most important point we should always look. What are its components? It is basically has three components. First, correction and optimization of preoperative anemia. Second, strategies to prevent blood loss. And third, allowance of permissible anemia. So, anemia and iron deficiency should be assessed and treated with B12, iron preparations, then erythropoietin stimulating agents, and it should be identified, screened, and optimized preoperatively. Strategies to prevent blood loss is use of epsilon aminocapric acid, tranexamic acid, reduce priming volume on CPB, retrograde autologous priming on CPB, use of red blood cell salvage, and in post-operative area, use of allowance of permissible anemia. We should keep in mind that all the recent evidences and guidelines say that RBC transfusion is unlikely to be benefit in the non-bleeding patients with a hemoglobin of more than 7.5. Incidence of atrial fibrillation post-operatively is around 15 to 40% cardiac injury. And increased incidence of post-operative AF increases ICU length of stay, increase in mortality, morbidity, and increased incidence of stroke. So before prevention and treatment and prophylaxis, we should always stratify the risk. Which patients are more prone for development of postoperative AF? There is a risk scoring called CHADS VAS score. What it denotes? C is for congestive heart failure, H is for hypertension, A2 is for increased age more than 75 years, D is for diabetes, S is for prior stroke or transient ischemic attack, V is for vascular disease. The second A is for 65 to 74 years of age, and S is for female sex. Presence of more and more of these factors preoperatively increases the incidence of postoperative AF. So we should always stratify the risk. And what are the guidelines for the medications? Inclusion of beta blockers preoperatively or immediate postoperatively as oral or IV agents, and preoperatively high risk or immediate postoperatively oral or IV amiodarone. With regard to the procedures, increased incidence of pericardial effusion increases postoperative AF. So procedures like posterior pericardiectomy and avoidance of retained pericardial blood should be done to avoid postoperative AF. Surgical site infection. The less the infection, the more the patient goes to the wards and wards to home. So we should always follow the guidelines and recommendations which are there for reduction of surgical site infection bundle. They have been categorized as preoperatively, intraoperatively, and postoperatively. What we should do preoperatively: smoking cessation for 4 weeks, topical intranasal staphylococcal decolonization, chlorhexidine alcohol-based bathing a night before surgery, intraoperatively clipping of hairs as opposed to shaving. In many centers, we still do shaving. Chlorhexidine alcohol-based solution for skin preparation, use of antibiotic within 1 hour of incision, and routine use of insulin infusion intraoperatively for glucose management. Postoperatively, avoidance of hyperglycemia. The goal of glucose intraoperatively and postoperatively, according to all the evidences now, is 140 to 180. And maintenance of normothermia between 36 to 38 degrees Celsius. So we are at end of our PPT now. The lady which you can see, she is post-operative day 1. Video was taken in the evening of day 1. Her lines are out, her urinary catheter is out. She is absolutely pain-free because of regional anesthesia techniques. We should listen what she says.
माझं ऑपरेशन काल झालं.
आज तुम्ही सकाळी उठून बसले सर?
हो, मी आज सकाळी उठून बसले आणि 15-16 अशा फेऱ्या पण मारल्या.
सकाळपासून काय काय खाल्लं?
सकाळपासून मी चहा, कॉफी आणि सूप घेतलं.
आता तुम्हाला कसं वाटतंय?
आता मला खूप छान वाटतंय.
काही त्रास
नाही, काहीच त्रास नाही आता.
तुमचा अनुभव कसा आहे इथला?
माझा अनुभव खूप चांगला आहे.
The second slide is post-operative day to CABG. This is what ERAS should look like, and we should always practice our perioperative work to achieve this. Thank you.